welcome you all to our ethics rounds. And today we're going to talk about culturally responsive medical care, or embracing cultural diversity in the practice of medicine. So let's start off with the first case. A 36-year-old agricultural worker from Samoa developed Cryptococcus meningitis infection with sudden blindness and obtundation. He responded slowly to intravenous administration of amphotericin B. Midway through a planned 6-week course of an antibiotic, he suffered a stroke. His family requested discharge so they could use traditional therapies, including topical leaves and lotions and an oral herbal mixture. His physicians were reluctant to allow him to go home, recognizing that his only chance for survival was with the continued use of intravenous antibiotic therapy. So, what should we do at this point? Okay, someone needing continual antibiotic for the Cryptococcus meningitis. He suffers a stroke, and now the family is saying, you know, let's just take him home where we could use our own therapies. And the physicians are thinking that there's still a chance for recovery, whatever that might be. So what should we do in this case? We elect not to call in psychiatry, though they're very helpful in difficult cases. But in this case, he's responsive to only pain and occasional commands, and it's assessed rapidly that he does not have decision-making capacity. But that's always the first thing to think about. Okay, so yes, Joe.
What's the prognosis, and does the family understand?
Yeah, well, the prognosis is 10%, 20% chance that he'll recover. And the family, they take that all in, but they think that they could do better now with their own therapies. Yeah, Karen. Okay, all right. So you're saying, what are these therapies? And maybe the family could bring them into the hospital, and one could have concurrent therapy, complementary therapy, stuff like that. What do you think about that? All right. Okay, good. And actually, we had talked about that. And here's my little table. You'll be seeing this as we progress along. And there's always, I guess, 3 things we could do in these cases. We could intervene or not allow, we could allow, or we could mediate a middle ground approach. And essentially, that's what was done here. We said to the family, listen, he could still have a good recovery, and why don't you bring your stuff here? We don't object to that, as long as it doesn't cause harm. And we've had previous cases in which families wanted to bring in magnet therapy, and magnet, not maggot therapy. Essentially, a running theme through this presentation is cultural issues that cause conflict. Here, one could label this as folk medicine. One source of misunderstanding in healthcare stems from the practice of various folk treatments. Many patients and family members would resort to multiple healthcare systems simultaneously, Western culture and folk healings, or I should say a more neutral word would be Western medicine plus complementary medicine, acupressure, acupuncture, and other types of complementary therapies. And essentially, they can successfully work together in the care of patients. And I have a whole list of cultural issues that could cause conflict, and this is the first one on the list, and we'll discuss many of these as we go through the presentation. So let's go through this case. Patient is a 33-year-old African-American male, admitted to shock trauma, injuries from an MVA, Patient does not suffer any head injury and appears fully conscious. He needs an operation to fix his long bone fractures. Anesthesia discusses with the patient regarding consent for the operation and for blood transfusions. The hemoglobin is 6.2. Patient gives normal is anything above 10. Patient gives consent for the operation, but he refuses consent for the blood transfusion, saying that he follows the practice of the Jehovah's Witness faith. He also states that it's not necessary to talk to his wife about this decision. The anesthesiologist and other care providers believe that the patient is competent to make medical decisions. So, should blood be given? Okay. Anybody say yes? Okay. So what happened in this case was that the patient goes to the OR, and the anesthesiologist then requests an ethics consult just to make sure they're doing everything right. The ethics consultant speaks with the patient's family in the waiting room, and they confirm that the patient has repeatedly said in the past he does not want blood transfusion and that he follows the Jehovah's Witness teaching, but he is not literally a card-carrying member of the Jehovah's Witness faith. The wife arrives and is angry to hear that blood will not be given. She talks with the ethics consultant and states that consideration should be given to the fact that they have 2 young children and they need their dad. So, does that change anything? Anybody want to say yes? Doesn't change anything. Okay. All right. Should blood be given? Blood was not given. So we allow the refusal for Jehovah's Witness individuals. And this goes under religious beliefs. However, the story does not end.
I'll wait till the end of the story.
Oh, okay, great. All right. Blood transfusions are not given, and after surgery, hemoglobin is now 3, and now the patient has an ischemic leg, suffering from a compartmental syndrome. Treatment is surgery, without which the patient would lose his leg. The surgeons are refusing to operate unless they could give blood, since surgery will involve cutting into tissues, which will result in further blood loss. If no operation is performed, the patient will definitely lose his whole leg. Patient is now incompetent, and his wife is demanding blood transfusion and thus wants to override the previous desires of her husband. Okay, I've upped the ante a little bit. Okay, should blood transfusions be given? That's a good question. Now, the patient had made a decision before under one situation. Now that the situation had changed, the risks and benefits are a little bit different now. Should we now listen to the wife? Tough case. So what happened was the treating team decides to follow the patient's previous wishes and surgery is delayed. The wife comes in with a lawyer and later on the judge, who visits the patient by the bedside and says that blood transfusions should be given. Patient is taken to the OR, but the leg cannot be saved and a hip amputation is performed. Patient recovers, is sent to Kernan for rehab. After a month, he comes back to University of Maryland for tissue infection. And I had the opportunity to talk with him. And I said to him, I'm sorry that, you lost your leg. He recognized that, appreciated that. And I said that, after you were taken to the OR, you were unconscious, and you were given blood. Do you realize that? And he said, yes, I realize that. And I said, so how is your relationship with God now that you were given blood? And he said, it's fine. Everything is fine. And I said, if you were to need blood in the future, what would you say? And he said, no blood. And I said, if you were unconscious and your wife wanted you to have blood and we gave you blood, what would you say? And he said, that'd be fine. that'd be fine. So, it's just really tragic. You just don't know when no means no. So something to think about for the future. Next case, patient 13 years old, suffers leg injuries from an MVA. Patient, no head injury. He needs an operation to fix his long bones. Also noted to have active bleeding from his stomach. Anesthesiologist, he needs an operation, and there was also consent for blood. And the family was refusing blood transfusions. So what should we do now? Should the medical team listen to the parents and not give the blood transfusions? No. Two emphatic no's. Okay? It's essentially the child is a vulnerable person, and the state has authority in its role as parents pater, protecting the vulnerable. So parents who are refusing for their child, we intervene. Okay. For an adult, we allow, unless we know otherwise. Yes? No, you don't. No, you don't. Maryland law states that, well, I shouldn't say it states it specifically, but it's common knowledge. And you could have help from the Jehovah's Witness representatives, and they will back us up. One does not have to go to court for this. It should be done immediately. All right, so let's go to another easy case. Okay, patient is a 3-month-old with trisomy 8p, inherited chromosomal abnormality with mental and cardiac abnormalities. Patient has respiratory failure and heart failure and prior repair of a congenital heart abnormalities. Parents are from Nigeria. At a family meeting, the doctors discussed the boy's prognosis to include several mental disabilities, growth retardation, and that the 5-year survival was probably less than 10%. Doctors did suggest that further medical therapy, like to fix further cardiac abnormalities, could be tried to enhance the likelihood of survival. The father, however, was adamant that they should take the boy home and stop the suffering. The wife did not say anything during the meeting, and any questions directed towards her, the husband would answer for her. As leader of the family, he felt it was his role to act as an intermediary between his wife and the world. But in conversations with the nurses, the wife had stated that she wants the baby to live as long as possible. The medical staff is concerned that the wife is unable to express her opinions in front of her husband. Okay, what should be done? Should we try to empower the wife in any way, or to just say this is a cultural issue? Let them handle this on their own. Now you're dealing with parents, individuals from a highly male-dominant culture. So what do you do? Do you try to empower the woman, the wife? Should we put on the table that we should try to mediate and see what happens, and see how vociferously the husband come down on us, on the situation? We did approach the wife, and she said, I don't want to, I don't want to confront him. Just don't do it. And because of her concern of the breaking up the family unit, what finally happened was that the husband got more information from his extended family in Nigeria, and he started to put 2 and 2 together that there were other children in the extended family who had similar symptoms in the last like 10, 15 years, and they all died like before 5 years old. And it finally clicked to him that the prognosis, was going to be very bad if one could generalize what happened to other family members to his child. So he became even more convinced that continued treatment would only continue with the suffering, and so we held back, and the wife became essentially didn't want to talk about it anymore. Don't really know if she actually felt comfortable with that decision in the long run. Brain death, okay. 12-year-old boy admitted with mental status changes. He has a history of a partially resected brain tumor that has been unresponsive to chemotherapy due to respiratory failure. He is intubated, given ventilatory support. Next day, he loses all brainstem function, and clinical testing reveals that he meets the neurologic criteria for brain death. Accordingly, the doctors pronounce him to be dead. Doctors approached the parents regarding the removal of the ventilator. Both parents, Orthodox Jews, refuses to have the ventilator withdrawn, saying that their religious beliefs do not recognize the concept of brain death. What should be done? There are different religious beliefs. In New Jersey, it's written in the law that someone could claim a religious objection to brain death. And in New York, it's not written in the law, but it's accepted by the hospitals and the doctors that one would defer to a religious exception. So in this case, we would allow the family's refusal. I mean, what happened in this case, several days later, the boy lost cardiac function. Another case involving brain death, 56-year-old, acute cardiac arrest, treated with aortic balloon pump, ventilatory support. During this time, his family is frustrated, angry, and the conversations revealed they think there have been several medical errors. After the third week, the patient's mental status deteriorates. Clinical testing compatible with brain death. The physicians tell the family that the patient has died based on neurologic criteria and that the ventilator will be withdrawn. The family objects, saying they never heard of this concept of brain death, and they're also now very suspicious of the medical system, the doctors. Okay, so what should be done in this case? Is this the same case as before with the religious exception? They're not invoking any religion in this case. Yes, they don't believe the prognosis. They see someone who's warm, the heart is beating. The concept here is that one should try to mediate, not allow, not necessarily intervene, but give more education, and hopefully over the next 12, 24 hours, they'll be more accepting of the diagnosis. But I think when push comes to shove, in cases like this, one has to go forward and withdraw the ventilator unless there's other extenuating circumstances. So I just put this case up as a mirror to the previous case with the religious exception. Okay, so what is culture? We've been talking about that. So what is culture? So learned pattern of knowledge, beliefs, behaviors, norms shared by members of racial, ethnic, religious, or social group that is passed down from one generation to the next, the non-physical inherited traits that we possess. Much of what we believe, think, and do, both consciously and unconsciously, is determined by our cultural background. Essentially, one could ask, who am I? Okay, and it's really all influenced by primary dimensions in this inner circle, and secondary dimensions also influence our actions, our belief patterns. Values are the things we each hold as important. Western society value autonomy, independence. Eastern society, family over the individual, a web of relationships. Prefer to make decisions as a group and to assist the patient in self-care functions. So we have individual values versus group values. One reason for so many conflicts and misunderstandings is the great difference between the values of the healthcare culture and the patient population. So essentially, what we have, the problem is we have a gap in values, okay? 26% of the U.S. population are ethnic minorities. The strong majority of healthcare professionals are, that's right, Caucasian. There is hence a large cultural gap between the Western medical system and the huge number of diverse ethnic culture that we serve. Most of us, even though we may consider ourselves free of prejudice, probably are not. And maybe prejudice is not the right word. We're all doing, well-meaning. It's just a lack of knowledge, or maybe even sensitivity, if I may say so. So what is culturally responsive medical care? Medical care that is adapted to meet the cultural specific aspects of individual patients. Cultural responsive medical care holds culturally sensitive attitudes towards health traditions among diverse cultural groups. The ability to function effectively in the context of cultural differences. Now, that does not mean that caregivers need to be knowledgeable of all the different cultures, but one needs to be sensitive and seek knowledge from the patients and family members themselves. And caregivers need to be aware of how cultural customs and beliefs influence health behaviors regarding illness, how an individual's explanatory model of disease is shaped by their culture. Also, caregivers need to be aware of their own cultural values and how they might inject their own values into patient decision-making. Another issue, cultural issue that causes problems. Middle-aged Chinese patient refused pain medication following cataract surgery. When asked, he replied that his discomfort was bearable and he could survive without any medication. Later, however, the nurse found him restless and uncomfortable. Again, she offered pain medication. Again, he refused, explaining that her responsibilities at the hospitals were far more important than his immediate comfort, and he did not want to impose on her. Ethics consults called and counseled the staff to firmly insist to the patient that his comfort was one of their most important responsibilities. Subsequently, the patient finally agreed to take the medication. I think that, I don't know if we have anybody from the pain service or palliative care. Concepts of pain, a cultural issue that could cause conflict. Some generalizations about pain, expressive or emotive patients often comes from Hispanic, Middle Eastern, Mediterranean backgrounds. Stoic patients come from Northern Europe and Asian backgrounds. Hence, when treating a patient from a different culture, the patient's concern for the symptoms must be treated with as much concern as the actual physical symptoms that are present. We have to be aware of these potential cultural difference in the concept of pain. Well, let me skip that slide. Okay, another case. Patient is a 26-year-old Armenian male with 3-year history of sarcoma, metastatic lesions to the lung, which has remained stable with chemotherapy. Patient was admitted with hemoptysis and underwent lung resection. Hospital course complicated by ventilator dependence, bronchopleural fistula, and pneumonias. During the hospital course, the family has begun to camp out in the ICU. And essentially, a member of the family is always present in the room. How many people have been exposed to that type of situation? Okay, right. Okay, good. So, all right. And in fact, you tell them about the hotel down the road, and they say, we're happy here. Okay, we're happy here. Okay? The mom is present more than any other family member and begins to direct care. For example, refusing pain medications for the patient, determining when the patient can go down for diagnostic testing, and controlling what kind of information can be told to the patient. For example, when a CT scan shows that additional nodules appear suggestive of progression of the tumor, the mom refused to have this information given to the patient. Nurses are getting frustrated on multiple levels. An ethics consult is called regarding truth-telling. What's happening here? What should be done? Yeah, it's a good point. It could be that the son is who's also enmeshed, in this cultural notion of the family caring, and the only way to care from a family point of view is to quote-unquote camp out in the ICU and always be there. Curtains are drawn, and always watching all the procedures. They take it upon their what term am I looking for? That's what they're there for. That's what they're supposed to be doing. In fact, that's what they do if they were back home. They'd be, and I say this in a positive way, hovering over the patient, caring to his every needs. And so essentially, visitors and family, or visiting and family, respect felt for family members. When one member of the group is ill, the whole group is ill. The whole group is ill. And they share that concept, that perception, that feeling. Everyone is ill when one person is ill. Why are they so demanding? In Middle Eastern and Far Eastern cultures, the way that family members show their love and concern for their loved ones is to make sure they receive the best care possible. The way to do this is to insist that the staff do their jobs, in fact, do more than their jobs. That's what they're there for. We see them, the family, as being demanding. They see them as, that's what they're there for. Visitors and family is on the list. The last case, patient is a 64-year-old from Pakistan who is hospitalized for pneumonia. Chest X-ray also shows a suspicious mass lesion. For the last few months, he has been treated for tuberculosis via directly observed therapy. His son is responsible for being the observer for this therapy. Bronchoscopy is performed. Cytology is positive for cancer. The son asked that his father not be told, saying that in his culture, one does not tell the elderly bad news, and expected that the family controls access to such information. Medical staff is conflicted. They're concerned that if they go against the son, the son will stop caring for the father, who's dependent on, with this directly observed therapy. What do you do in this situation? I wanted to get back to this truth-telling that, reared its head in the previous case as well. So how do you mediate, negotiate? When family explains this, they say, listen, in our culture, cancer is a death sentence. If you mention the word death, if you mention the word cancer, people clam up and they'll die in a few days because they know they're coming from an area where there are not treatments for cancer. And that's why they have this notion that cancer is a death sentence. Also, there's the concept that one is trying to protect the elderly from bad news. Okay, right. And that's similar from what was said before. You allow the patient to express their autonomy by asking them, how much information do you want? Do you want to defer, do you want to make an autonomous decision to defer your autonomy? And in fact, we actually embrace the same thing in the American culture. If you look at some of the advanced directives, they say, and I think it's in the Maryland form, they say, now, when you're filling out an advanced directive, obviously you're competent, and you have two options. One, regarding when the concerning your healthcare agent making decisions. You have two options. One, do you want your healthcare agent to make decisions for you after you've been declared incompetent, or do you want your healthcare agent to start making decisions now? And sometimes people do check off, I can't make decisions anymore. I want my healthcare agent to start making decisions for me now. So essentially, this is a similar thing. So essentially, you place choice of disclosure with the patient, You follow the patient's wishes, abide by the family only if the patient requests that communications be done through the family. That satisfies HIPAA. You offer the truth. You ask patients what they want to know. Disclose if the patient asks. That's the tell only ask policy. And you tell the truth, you tell as much truth as the patient wants to know. Cultural responsiveness is not mastering knowledge of all cultures. Culturally responsive physicians, caregivers, communicate with patients to better understand their explanatory model of disease, help patients communicate information that will lead to better health outcomes, and we need to recognize our own cultural beliefs and how they may cause biases. So with that, understand patient values, our values, and that will lead to enhanced understanding. And let me say thank you for your participation, and see you next month.